All right, guys, welcome back to the Progressive Rehab and Strength Podcast. I'm your host, Dr. Rori Alter, head clinical coach here at Progressive Rehab and Strength, with my lovely husband, also a clinical coach here at Progressive Rehab and Strength. We're both physical therapists, and this question today we're actually doing one of our questions for our Q&As, and this question is really a pretty awesome one, and it's not really along the lines of a power lifter. It kind of ties in like the actual like outpatient and acute care setting into barbell training and all that kind of stuff. So it's exciting. All right. So this question that we received is a very special question because I think it really shows us how strength training is very important as we age and how it can also be used in the rehab setting for the aging population. And so this question comes from not a client of PRS, but a longtime follower of PRS who actually has taken some of our courses, and she is a 75-year-old barbell trainee. She's been barbell training for about 10 years. And she sustained a wrist fracture and a hip fracture in March because of some sort of incident with a dog. I'm not really quite sure. I think the dog was coming at her or something like that. And she fell and fractured two areas of her body and ended up in the hospital and was discharged relatively quickly to home. So when we think of a 75-year-old who has fallen, whether it's just a trip and fall or, you're getting attacked by a dog or scared by a dog, a lot of the times these injuries, you'll end up staying in the hospital for a bit longer. You might have to go to rehab, especially if you're not weight bearing or you can't use a leg and you can't use an arm. A lot of people can't just go home after that, especially at 75 years old. But Pat did not qualify for rehab, so she went straight home. So I think that's a testament to really how protective strength training is and why strength training is really important as you age. So props to Pat for being strong and being able to handle this unfortunate circumstance much better than a lot of 75-year-olds would handle it. But she reached out to us to ask about how she can stay strong and continue to strength train or get back into strength training during or after the rehabilitation process with this injury. So, just a little bit about it. So, like I said, she's 75 years old. She fractured her left hip and her left wrist. Both the radius and the ulnar were fractured, and she had surgery. I believe the surgery was on her arm the same day, and she's weight bearing as tolerated, meaning she can put weight through that fractured leg, but she cannot put weight through her upper extremity because of the surgery that she had. She was discharged home after 3 days, but didn't go to rehab. And she's currently using a walker, but progressing towards a cane. And hopefully, obviously, the goal would be to not use any assistive device after she's fully rehabbed. And she said that she's not really having much pain. She's having more pain in her wrist than in her hip, which makes sense because she had surgery on the wrist. So that fracture was probably pretty bad and unstable. And she gave us a little bit of info about her former working weights, where her deadlift was about 120 pounds, her squats about 55 pounds, overhead press 40 pounds, and her bench press 55, which is funny because her bench and her squat are very close together. And I actually see that a lot in the older population, especially when they've started barbell training much later in life, in the later decades. A lot of times their squat and their bench press are pretty similar. Okay, so John, one thing, her goal, like I said, is to integrate barbell training into rehab and and ultimately stay strong through this process and not let the injuries deteriorate her as they would for many people who don't barbell train or don't go into these types of injuries with strength as their foundation. So, John, what are your initial impressions about this lovely woman?
Well, just to kind of reiterate some of the things that you said, the fact that she's 75 years old and had a hip fracture on top of a wrist fracture and didn't have to go to rehab says a lot about her
Hmm.
just general health and physical capability, right? Because typically rehab is a place that you go because you're not healthy enough or well enough to go
Or
back
strong
home,
enough.
right? Right. Yeah, exactly.
Yeah.
You're not physically capable of being safe in your own home, of being able to navigate, in your own home. So rehab is kind of this intermediary between the
Hmm.
hospital and being discharged home. So the fact that at 75 with those injuries, she's able to go right home, I think says a lot about her.
Yeah,
Um,
well, I want to chime in there, and just for people who are listening who either have parents who are older, or you are the person, this population, what they're or any and really anybody in the hospital, what they're doing when physical therapy and occupational therapy assess you to leave the hospital, they're looking at how far you can walk. Can you navigate stairs? Are you able to toilet yourself, clean yourself, bathe yourself? And are you safe? Can you move in your own bed, in and out of your own bed, in and out of a chair? So, like, how capable are you of being safe and independent at home relative to your home situation or your home environment? So they'll get all that information about your house, your apartment, your home environment, who lives with you, who doesn't live with you, and see if you are physically, physiologically, like medically, safe enough to go home and strong enough to take care of yourself. So Pat, props to you, because you are, despite having two areas of your body that are fractured.
Yeah. And just a couple more things. She doesn't explicitly say that she didn't have surgery on the hip, but the fact that
Hmm.
she's weight bearing is tolerated to me tells me that it was like a non displaced hip
Yeah.
fracture that she's able to kind of weight bear on. And
And
that the
I feel like
surgery,
she
like
would,
you
because
said,
she told us she had surgery on the wrist. She probably would have told us that she had surgery on the hip too. So
yeah. And
I'm gonna guess that she didn't.
right. Just so people, if they're not familiar with the anatomy, so she fractured her radius and her ulna, so both of the bones that make up the forearm.
Mhm.
Um, and she had, if you have surgery on a fracture, it means that it's a displaced fracture. And they do what's called an open reduction with internal fixation. So they basically
Pins and
situate the
rods.
bones, right? They line everything up and they stabilize it with with
Internal.
internal fixators, right? Screws, rods, pins, whatever they have to do to put it back together. So anytime someone has surgery for a fracture, it means it's a pretty bad fracture.
Mhm.
And the fact that she's non-weight bearing through that upper extremity is pretty common after those types of surgeries because you need time for the bones to obviously heal and be able to tolerate compressive loading again. The one thing that I'll say though, it's interesting that she's using a walker
Well, I was just gonna bring that up. They
when
have the
she
walkers that you can, put your
with the
forearm
hand, yeah,
with the
with the
hand, so that
handle,
it's weight
right,
bearing through the humerus, so weight bearing
right,
through the elbow. So it was probably like a distal,
yeah,
forearm fracture, and
right,
she's weight bearing through the elbow, through the upper arm. So yeah,
right.
that's probably the type of walker she's using.
But again, even like walkers can be a little bit hard to navigate, right? And
Mhm.
people that are on walkers because they,
You need a lot of
super
strength to use a
e-
walker.
exactly. And like if you can't like fully use your arms, it makes it
Even
even
harder.
harder. Um, so it's just kind of she's in a little bit of a tough situation. So obviously, if she can progress towards a cane sooner rather than later, then that would be a good thing for her.
But again, here's like the testament to the strength element of her, is that for a person who isn't strong and isn't strength training at 75 years old, if you had the same two fractures that she had, you might not even be using a walker,
Oh, 100%.
you
Yeah,
know?
that
So
there are a lot of people in her situation that would be in a rehab and be much much less functional than what she is. Um, and for those of you guys that aren't familiar with rehabs, I can tell you, nobody wants to be in a rehab, right? I mean,
everybody
it's
wants to get out.
right. Everybody just is dying to get out of those places, and it's nothing against the people that work there and that are staffing them. It's just you've had some sort of health issue, you've had some surgery or something like that, like you're tired of being in the hospital, you just want to get home, and so if you can avoid going, right, that's a big positive, I think.
Yep. It's always good to skip the rehab.
Right.
I
I mean,
mean, no,
obviously
don't
they're
skip.
no, they're necessary. They are
Yeah.
necessary for
Right.
people in certain situations,
But
but
if you don't have to end up there, it means that you're better off. You're in a
right.
better your situation is better, because also it's similar to a hospital setting, in that you're in bed more, you might, um you're not as mobile, so like you're probably sitting in your room or in a wheelchair most of the day. You got
Mhm.
your PT for 1 hour, your OT for 1 hour, maybe your speech if you're there for some neurological issue. You're not moving a lot. There's tons of other sick people there, and you can get hospital acquired illnesses in rehab. You're more susceptible to infection, you're more susceptible to bed sores, and whatever loss comes with immobility, because you're still immobile when you're there, or require more medical attention or assistance. So, if you go straight home, you're probably in a really good position to recover quicker than if you had to go to rehab. Um, okay, so Pat's goal is to stay strong through this process, and ultimately, I'm going to make some inferences from um, her email. Ultimately, to regain her independence and get back to barbell training. So what can we do when we are actually, I want to, before we go into things that we can do, I do want to preface this conversation with a disclaimer that Pat is not our client. She's not under our medical care. We don't have her entire medical history and details of her specific current injuries, and nothing in this episode should be considered medical advice for Pat or anyone else. And it's simply a discussion about how strength training is protective and concepts of barbell training and progressive overload that we can apply through the spectrum of rehabilitation in this type of situation and any situation similar to this. So please defer to your doctor and your rehab team for anything that you plan to do. What?
No.
Why'd you raise your eyebrows like that? John, there's so much going on in that brain that you don't share with people. Anyway,
I'm a man of mystery.
you are. I've been with you, what, for like 20,000 years, and you're still a mystery to me. Okay. Anyway, so let's talk about how can she train her upper body with and her lower body without the use of her arm.
Well, I think, lower body is probably a little bit easier to tackle since she's weight bearing as tolerated. And that essentially is exactly what it sounds like. It's up to her tolerance. So, um, I think that there's nothing really stopping her from starting with some partial range of motion, squatting or some assisted squatting, right? Holding on to something to kind of offload some of her body weight. Again, like you just said, we don't know her exact situation. So I'm trying to think of, like, if I had a patient in this scenario,
Right.
what are some of the things that I would be doing?
Mhm.
If I had access to a leg press, I would probably get them on the leg press to start at a load that's lower than their body weight,
Mhm.
if that was needed. Um, so the squat can certainly start to at least be introduced and progressed a little bit. And I think in terms of pulling, right, deadlifting mechanics, you certainly could do things without the use of the arms. And, we've talked about before on this podcast with people with other issues, shoulder, upper extremity type issues, using one of the deadlift straps, that
Mhm.
kind of go around your shoulder, so that you can essentially mimic the deadlift movement pattern without involving your upper extremities, right? Without really loading your arms. So I think that those would be appropriate starting points for
And this
her.
would be I think for someone like Pat who doesn't have the use of one of her arms, or anyone who doesn't have the use of one of their arms, in order to set up barbell lifts and use plates, you would need someone there with you. So I think that could be a limiting factor for a lot of people.
Sure.
Um, for a lot of us, we have home gyms, and in situations where we have injuries like this, it's sometimes beneficial to get, and Alyssa and I have talked about this on the podcast before. And we think sometimes it's beneficial to maybe during the rehab process get a membership to a local gym so that you do have access to pin loaded machines so that you don't have to be changing plates.
Yeah, I think that's an excellent point. I mean, as much as we love the barbell stuff and, would if we were working with somebody, that's what we would start them with. But, when we're working with people remotely and, we can't be there with them, a lot of times immediately post-op, a commercial gym, membership for a few weeks can be very
Mhm.
helpful in
Mhm.
just maintaining muscle mass and strength to the best degree possible while keeping you totally safe, right? The machines are, everything is balanced for you. Like you said, you don't have to worry about any sort of injuries loading and unloading plates and things like that with the pin loaded machines. So,
Mhm.
they do have a place in this like very early rehab phase, right? So,
Mhm.
any of the pin loaded lower body machines would be fine. And, that would also make upper body training a lot easier because she could very easily train the opposite upper extremity with pin loaded machines,
Mhm.
chest presses and overhead presses and things like that, and just do them unilaterally.
And I
Um,
think that's one thing that you really, really like with post-op people,
yeah.
people who have had surgery on either the upper or lower extremity, particularly I think in the upper extremity. You really have them train that other arm hard. You want to talk about that a little bit?
Yeah, I mean, there has been some research that shows a little bit of a kind of crossover effect to the opposite, extremity when you have a situation where you can't train, one of your limbs, whether it's your arm or your leg, continuing to train the other leg. I think sometimes people are like, well, I don't want to get so imbalanced that like I just am going to lay off of it. And in reality, continuing to train that opposite side seems to help maintain some of those neuromuscular connections, right? Even in the injured side. So it helps you maintain a little bit more muscle mass and strength than if you were to totally lay off training. So I do think it would be important for her to continue to train her right upper extremity while the left one is non-weight bearing. Again, machine based training is a nice option. If you're in a home gym or something like that, then using a dumbbell that is
Mhm.
secured, obviously, um, and mimicking whatever motions that she could in terms of like chest pressing, overhead
Yeah, and
presses, and
you
things
know,
like that.
even if you don't have a dumbbell situation going on at home, you can get resistance bands, and I think
Mhm.
I think and there's another, I saw a post in a Facebook group that I want to do a whole podcast on with you, John. So maybe I'll tell you about that when we get off recording here. But I think that people get so stuck in this like, well, barbell training, barbells only, and
Mhm.
there's like really no other way to do it.
Right.
But you have to look at the person as a whole, what they're capable of, what their situation provides them, and then make your exercise selection, your load selection, and your rep scheme and volume basically based on what that person's individual unique situation. And if someone's at home and all they have is a barbell and they can't do a bench press because they only have one arm to work with right now, and they don't have dumbbells and they don't have kettlebells and they don't have a landmine, or they do have a landmine but they can't carry plates because they only have one arm. Okay, we're going to load that other arm with a resistance band if that's all you have. And we can apply the concept of progressive overload, and we can apply the concept of a multi-joint movement to any other exercise and any other mode of exercise, if that makes sense, right?
Yeah, No, I mean, I agree. I mean, we obviously love barbells and we think that they have some very, unique advantages over other modalities of resistance training. But, in these unique circumstances where you have somebody that's injured, had surgery, and for a short period of time, they're not going to be able to access barbells. And any other form of resistance training is better than no form of resistance training, right? So
Exactly.
it's like you have to work with the individual that's in front of you and be flexible in kind of your approach. But I think the principles
Hmm.
that we kind of use in barbell training, right? Trying to utilize exercises that incorporate a lot of muscle mass and multiple joints and progressive overload, those should still be applied to rehab, whether you're doing it with a dumbbell, a band, a plate loaded machine. Those are still things that I think have value regardless of the modality of training.
Yeah. And she might even be able to do like a row type movement. Um, I mean, I can't say for sure.
It
Um,
depends on the setup, right? I mean,
yeah,
there's a lot of different ways that you can try to set things up. I mean, it's not going to be perfect for her because, obviously her left lower extremity is compromised, so her ability
right,
to kind of stabilize
right,
herself will be a
right,
little bit thrown off, and her she's not going to be able to use the left upper extremity to like again help her kind of balance and stabilize for
right.
certain exercises. So it's definitely complicated, but there are things that she can do safely to just help her rehab get off to a good start.
Yeah, and just to discuss the ways in which we can apply progressive overload if it's not this like incremental increase in load with the same number of reps and sets every time for the same
Mhm,
exercise. We can do things like use the same load and add more sets, use the same load and add more volume, um, increase the range of motion.
mhm.
What else can we do?
Yeah, I mean, those are all things that I use
you know?
for
Yeah.
rehab
Yeah.
patients and clients all the time because honestly, I mean, in some situations, going up in load every single time just isn't either feasible or sometimes it's like scary to the person,
Mhm,
you know what I mean?
mhm,
So, but I do try and get them to do a little bit more every time in some form or fashion, right? So, like you said, you can ask them to do an extra set. That's a little bit more stress than what they did last time.
mhm.
Or you do the same weight for the same number of sets, but you ask them to do a few more reps, right?
Mhm.
Anything that kind of keeps them progressing and you're not just kind of going through that traditional PT of doing the same thing over and over again,
Oh,
thinking that it's
that's
going to
my
get
yellow
your
band. I'm gonna do 3 sets of 15
right,
now. That
right, exactly.
exercise, I use the yellow band.
Yeah,
That's what the ladies tell me in PT.
yeah, and like you said, sometimes for in these situations, just increasing the range of motion is a
Mhm.
stress in the exercise. So, like if she's starting out with a partial range of motion squat,
Exactly.
the next time, if she can move through a little bit more range of motion, even if it's the same load, that's
Mhm.
more stress, and it gives her something to continue to like drive adaptation.
Yeah, I think that, like, sometimes with hip fractures or, um, hip surgery or replace hip joint replacement or even with the knee, we'll do, like, a partial range of motion squat for a couple weeks, progressively overloading with the load, and then we'll pull back on the load and increase the range of motion a little bit and then rebuild for a few weeks
Yeah,
there's so many different ways to do it as long as you're increasing something every time,
right. Yeah,
you
I
know?
mean that's pretty much the approach that I take. A lot of times, what I like to do with people is alternate between increasing load and increasing
Mhm.
range of motion. So, like one session we go up in weight, the next session we keep that weight the same, but we increase the range of motion a little bit. So this way, it's kind of like this alternating, um, approach. But there are lots of different ways to do it, like you said.
Yeah, and it just depends on how fast your range or your tolerance can progress too, or
Right.
is allowed by the surgeon,
Well,
so
that's exactly what I was just going to say. I mean, in some cases, you are somewhat limited by post-operative
Mhm,
precautions or
mhm.
recommendations, and there are certain things that are contraindicated, right? Which means you cannot do them, and you're really opening yourself up to a lot of liability if you violate some of those things. So you do have to just use common sense and be smart about how you approach some of this stuff.
Hmm. So things that we should be focusing on in the early rehab post fracture. Well, let's talk a little bit about like fracture healing timeline, and why, um, what this kind of looks like in terms of gaining range of motion back, your pain levels, how much you can or can't move. Like, why do we immobilize fractures, and why might we not immobilize fractures? You know?
Hmm. Well, I think that when you look at general timelines, right? A lot of times they'll say like 4 to 6 weeks, right? I think 6 weeks is kind of a good general timeline for tissue healing, right? Whether we're
Hmm.
talking about bone tissue or following a tendon repair surgery or something like that before the repair or the fracture is ready to start handling some higher intensity of compressive loading in the case of a fracture or tensile strain in the case
Hmm.
of a tendon. In terms of whether or not something is immobilized, it kind of depends on the area of the body, right, that we're talking about, and how much um, compressive load is typically transmitted through that area. On a with our activities of daily living and things along those lines, and um, so, we don't really know in terms of Pat's particular injury exactly where she fractured the hip, right? A
Hmm.
lot of times,
I have
you
a
could,
feeling it was like a pelvic fracture.
right, probably
Yeah.
probably a non-displaced pelvic
Yeah.
fracture if she didn't have to have surgery.
Yeah.
When you hear about um,
Fell and broke my hip.
older people that fracture their hip that need to have surgery, a lot of times that's
Femoral.
like the proximal femur,
Yeah.
right? So the femoral neck, through the or a trochanteric
Mhm.
fracture,
Mhm.
right through the trochanter. So, but like in the proximal femur, closer to the hip joint, but it's like the femur, not actually the pelvis.
Mhm.
Um, so like if you fracture your pelvis, like you're not really putting a cast on that. You know what I mean? Like
Exactly.
there's not. So
I
um,
mean, even when you fracture your hip and have surgery, they don't put a cast on it.
No, for an ORIF in the hip,
Yeah.
they definitely will not do that. I mean,
Yeah.
um, for something like that where there's a wound, right? They don't want to cover that up, and then you have like a risk of infection and those sorts of things. So fractures are more common, that you would have a cast if it was non-surgical, right? And obviously, it's an area that's like actually feasible to cast. You know what I
Mhm.
mean?
Mhm.
So like I would guess that even though she's non-weight bearing in her wrists, like because she had an ORIF, she probably does not have a cast on that. You know.
Yeah. So during the rehab process, especially when we're immobile or non-weight bearing, we're going to lose. I don't know, want to say that we're going to lose range of motion, but we tend to start to lose range of motion because we aren't using that range of motion. Plus, there's the development of the scar tissue in the bone, in the tendons and ligaments and all that stuff that's in that area, plus the surgery that she actually had. So there's going to be some stiffness and loss of mobility in probably the arm more than the leg. But once we're allowed to, I think she'll probably be allowed to move though. She's non-weight bearing, but she's probably allowed to move as much as she can. And I think that the key here is to move within your pain tolerance so
Hmm.
that you don't lose mobility. So it's not just about making sure that you're getting in your strength training, but it's also making sure that you're using your limbs and your fingers and whatever your elbow, your shoulder, whatever you can to
Hmm.
maintain as much mobility as comfortable during this time so that you don't have to regain as much after you're not in a ton of pain and when you start to weight bear through the arm and then can load a barbell.
Right. Yeah, so in situations where people are non-weight bearing, a lot of times they're still referred to physical therapy for like passive range of motion,
Mhm.
you know, active range of motion in a non-weight bearing
Mhm.
position, things like that. So for her, certainly what sometimes tends to happen to people if they have, let's say, an upper extremity issue, but it's not, it's in her wrist, but like because they're not using that arm, they could get stiffness in their
Mhm.
shoulder or their elbow. So like she should be doing as much active range of motion as she can for her shoulder and elbow.
Mhm.
And, like you said, her wrist within her pain tolerance, flexion and extension, pronating and supinating, the
That's gonna be
forearm.
pain that's
That
probably the most painful.
Right, but if she doesn't do any of that active motion
Right.
or, have somebody doing a little bit of like passive range for
Mhm.
her, that's gonna
I
get
wish you lived
more
near
stiff.
us, Pat. I want you to come see us.
um, so those are like little things that and it varies so much sometimes between surgeons, right? Some surgeons will send people home like these are exercises I want you to do at home, and usually it's very basic stuff, right? Other surgeons like don't give people any instructions, so they don't really know what they should and shouldn't be doing, and a lot of times they end up having more stiffness or maybe complications in terms of getting back to their regular function because they detrain so much, right?
Mhm.
They get more stiffness and things like that. So I think for her, keeping that upper extremity moving as much as she can tolerate without actually loading it will
Mhm.
help her kind of transition back to more normal function sooner.
Yeah. Move it or lose it, baby.
Mhm.
Motion is lotion, right?
Mhm.
These phrases didn't come from nowhere. They're like they're it's truth. Um, so definitely focus on the in during this early stage on maintaining mobility as much as you can within pain tolerance, moving and progressing some sort of strength training um, within ranges and movement patterns and modalities that you have access to and can use based on your own restrictions. Um, Going in and seeing a physical therapist in person as much as your insurance company will allow. But also consider what your insurance company I mean, this is probably a Medicare because of her age. So you do wanna consider, like, spreading your physical therapy out so you could get the most out of it, if you can't do that much now, maybe going 2 or 3 2 times a week, get some exercises and do as much as you can at home, and then when you're able to tolerate more and you have your restrictions lifted, then go in for more physical therapy so you can have more, supervised, um, strength training, and find a physical therapist who will do strength training with you, because that is not always the case. You might get
Yeah.
the there you might be in an area or know the physical therapy office that you first go to is like, "Okay, you're gonna do clamshells for the next 12 weeks, and we're gonna use the yellow for the next 12 weeks and do 3 sets of 15 for the next 12 weeks," and to me, that's like getting weaker,
Yeah.
essentially.
I, I think that the point about kind of spreading out the PT, that's it's probably more than people kind of who listen to this need to be cognizant of. But if you're on Medicare, as an example, you only get approved a certain amount of physical therapy over the
Mhm.
course of a year, calendar year, right? And you can apply for more and things like that. But um, so, a lot of times when I have patients, like if I had her coming to see me, right, I would only have her come once a week in these early stages,
Mhm.
and I would kind of give her stuff to work on her own, and then as she was able to do more, I would have her increase the frequency of coming.
Yes.
Um, so if she has the ability to get to PT, once, twice a week at the most, she should
Mhm.
not be going 3 times a week right now because she's going to burn through those sessions and be done before she can really start to like get her function back.
Yeah, so during this time, get a home exercise program from the physical therapist that you see, but also help ask them what you can do on your own at the gym. You can be going to the gym. As long as you're smart and safe about it and paying attention to your environment, and keeping away from people, like going at a slow time. I would recommend going at a slow time when it's not super busy. But you can use machines at the gym. And honestly, you could probably use a bike at the gym.
Mhm.
We can't neglect the cardiovascular changes that happen after this, because you're probably going to be a little bit less active, not walk around as much, not go out and about. So you want to maintain your cardiovascular strength as well, or health. So if your weight bearing as tolerated, you could probably get comfortable on a bike for some period of time. You can do that a little bit. Um, you want to get into the gym on your own with what you feel is safe and comfortable. Maybe you're working with a coach or a physical therapist to help design something that you can do on your own in the gym, in addition to like the rehab type exercises. Um, so, John, what, is it realistic for someone like Pat to return to barbell training after experiencing something like this?
Oh yeah, absolutely. I mean, if we're talking about in the longer term, I would have no hesitation saying that if she was training before, which she was, then there's no reason why she can't get back to training pretty normally afterwards, as she continues to heal. So, um, and like we've been talking about, I mean, I would kind of start to incorporate back a lot of the things that she was doing before with some sort of modification as early on in the process as I could, so that her rehab really goes from being rehab to kind of transitioning
Mhm.
into training over time,
Mhm.
right? And
Yeah.
it's not like she's just going to go to PT and, like you said, do the clamshells and like all these like little, kind of isolated, not really loaded exercises to then, okay, I'm cleared, I'm just going to go back to the gym now and start training. Like
Right.
really, it should be a gradual
Right.
transition where over the course of a couple months you go from doing a lot of these kind of really
Accessory or
low level,
isolated. Yeah.
right, like low level rehab type exercises to with a little bit of kind of the training aspect thrown in, to transitioning to now eventually you're basically back to fairly normal
Mhm.
training, right? And
Mhm.
there are always adjustments that may have to be, made to train around certain injuries that you get. So it's hard to say, right? I mean, if she may have some wrist discomfort, like as she's getting back into, squatting or pressing and things like that. So, she might have to adjust her grip or wear a wrist wrap, or, there are all these little things that,
Yeah,
you
and
know,
and
you
that
have to make adjustments to as they come up, but there's no
yeah.
reason to say that she shouldn't be training or won't be training.
Yeah, and I mean, to that point, I just want to remind everyone who's listening that rehab is not linear. As you gain more, in general, this is not just you, Pat, this is just everybody. As you gain more mobility, as your healing progresses, and as you become more active again, and you're doing more range of motion, you're using those limbs more, you're loading it more, you're getting more active in your daily life outside of the rehab setting, um, things can start to hurt a little bit, and that's normal. We just have to recognize it and say, "Oh, why is this hurting? Am I doing too much? Where am I doing too much? What can I adjust? And do I need more rest? Do I need more recovery? Is this, those kinds of things?" So we shouldn't fear pain. We shouldn't like be totally taken aback when there is pain as we're healing, because it's going to pop up. But we should use it to assess, like, why am I experiencing this and what can I change or modify, um, because of that little warning sign. Um, and I love that you talk about this like gradual transition from more of this like rehab lens to strength training lens, because that's really what it should be. We want to take those main principles of the squat, bench, deadlift, and overhead press, and the concept of progressive overload, and find the level, whatever exercise or piece of an exercise that is, whatever load and whatever rep scheme that is. And maybe we need to do 3 or 4 exercises to replace a squat in the early rehab phase. And eventually that will be replaced by the squat and maybe like one or two extra things to work on an area of weakness, which you're gonna have. Like, generally, if you're a healthy person and you're going into barbell training with like no injury, you shouldn't have like an area of weakness. Your body's pretty symmetrical, but when you're coming out of an injury, you might be weaker on one side. Your glute on the left might be weaker than the right. And do we need to do something else to help it catch up? Maybe. But eventually it will catch up, you know? And that could take a year, it could take 2 years, but you're not going to be, I don't think you're going to be out of this for as long as you would be if you weren't barbell training um, prior to this injury. So really, Pat, you're a perfect example for the aging population. And I use that as like you and I are aging, John. Like literally everyone is aging. Okay. We are. We're getting older. And strength training is protective as we get older. So, sure, strength training is great when you're a dad or when you have a physically demanding job, or and you need to be strong to do the things that you have to do. But also, when you get injured, when you're immobile or you're less mobile or you have surgery or you get sick, your body's gonna start to um, decline a little bit. And when your ceiling is much higher, you won't become like an invalid, basically. I hate that's like not the right way to say that, but you know what I mean.
Not the politically correct
There you go.
2025
I
term, but
know. I
well,
was
and
born in 1987. Okay.
to that to that point, the way that I would say, I mean, in terms of talking about ceiling, I would say that like, um, also your floor is a lot
Exactly.
higher, right? Like,
Exactly.
and I talked to my students about this. My students, they're all generally like in their, some of them are still in their teens, right, to early to mid 20s, and so they're not thinking in terms of like aging yet, right?
Right.
Like, I mean, when I was in my early 20s, I wasn't thinking about, what is it going to be like when I'm 50, 60, 70 years old? But, this is something that we talk about, is like building up your physiological reserves, right? And
Mhm.
I tell them, like, you want more muscle mass, more bone mineral density, like build it now
Right.
so that you have this higher reserve so that when you do eventually start to lose it, you're still much better off than, what you would be had you not been training and, taking this stuff seriously from as early an age as you can,
Mhm.
but um I do think that the stronger you go into these sorts of
Exactly.
situations, the better off you're going to be because you're going to have more
Yeah.
lean body mass, more muscle mass, more bone mineral density. So that if you lose some of it, hopefully you're able to gain it back, but you're not going to be as negatively impacted
Right.
as somebody that has really low levels of that stuff going into these
Yeah.
situations.
And yeah, I mean, even just using myself as an example, I had two very, very difficult pregnancies, very sick, lost a lot of strength during my pregnancies. But after, I was still stronger than the majority of the population.
Oh yeah,
I mean, I was, I don't even remember. I mean, I was deadlifting like in the 300s, like very quickly after I had JD.
right. So not
Um,
super strong for you, but still
right,
strong,
exactly.
still a lot stronger than the average person.
Exactly. And so you're like you said, the reserve is you've just like built it already. So Pat, I mean, I would not worry if you maintain the habit of training, and that could be your physical therapy. You're just going to the gym 2 times a week and doing what you can. Like if you maintain that, because the habit I think is the easiest thing to lose is the habit. And that's something that, on other podcasts you and I have talked about. My habit has, well, now it's back, thank God, since the last podcast episode that we recorded together. But I think the habit is what we see most people lose more than like strength and muscle mass um, during this time. So keep the habit alive, go to physical therapy, go to the gym, do what you can. Um, and we encourage you to like document this process, because I think that a lot of people would look at doctors, especially. I mean, doctors like be like, "Are you crazy? Like you're gonna barbell train?" But like, what? Well, is the person whose dog came after you crazy? That's crazy that that dog was able to come after you. Not barbell training. Barbell training is what enabled you to like be okay. you know.
It's funny that you think that it's a dog attacked her. I keep envisioning a dog pulling her, like her own dog, like on a leash, like
No, I
so
feel like
she
the
fell.
email said that a dog came at her. I don't know. I feel like
Uh,
she was attacked by a dog.
we'll need
We'll need
clarification from
clarification,
Pat.
Pat.
Most people that I've had that have been injured by dogs, it's usually been their own dog, like either
I need
running
to
and
see.
taking out their
I'm gonna
legs,
read the email. Hold on.
or chasing after something, and the person tries to stop them, and um, and they dislocate their shoulder,
Uh
or tear their bicep, or tear their
I
ACL,
fell
or
due
something.
to a loose dog running and growling at me.
Oh, okay.
It was not
So
her
you're
dog.
right.
I was right.
Okay.
What
All
did we
right.
learn here again, John? Rory is always right. Okay.
I learned nothing.
You learned nothing.
No.
Okay. So but yeah, document this for us. Like let's see your rehab. I'd love to learn more about your process. Maybe we could reach out to you, or you could connect with us, in a couple months and let us know how it's going. Um but
One
yeah,
thing,
yeah,
one thing I'll say, you mentioned like the doctors. My experience is doctors could care less, or what is it? Could not care less. They could not care
right.
less
Right.
about people's rehabs, and like when Pat goes back, and like if she's doing well, they're gonna be like, oh, that's great, great, just keep doing what you're doing, and that's it. My experience when I've had all these clients that have like barbell trained and successfully rehabbed, and they're doing so much better than their other patients, they have no interest in knowing why. Like,
Yeah.
and the very few of them that actually ask, when they tell the doctor that they've been like lifting weights and using barbells, the doctors think they're crazy. Like, instead of being curious about like, wow, that's kind of interesting that you're actually doing this different thing
Yeah,
and
they actually say like,
it's
"No,
working
don't do
so much
that."
better. Yeah, they're like, no, stop doing that.
And
It's like, well,
you're like,
that's the
"But
thing
I'm
that's
doing better.
helping.
I'm doing better than all your other patients. Like, why
Right.
am I going to
So
stop?"
if she
Oh my
documents it,
god.
it could help other patients in her
Exactly.
situation, but the doctors
Ugh,
aren't going to care,
yeah,
you know?
nah. I mean, there are some doctors who are
Right,
awesome.
of course. Very, yeah.
Yeah,
No,
but
there are lots of awesome doctors. There are very few that are actually curious about this stuff, I would say.
yeah. All right, Pat, thank you so much for reaching out and sharing this. I doubt that you thought we would do a whole podcast on this after you shot me that email, but I thought it was a perfect opportunity to talk about this and just get more older people under the barbell, and encourage people who are barbell training to not stop just because they're getting older or they've hurt themselves. And even if you've never touched a barbell, it's literally never too late to start barbell training. Some people actually like get into barbell training because they're in the situation that Pat's in, where they get injured and they go to rehab, and they'll be fortunate to find a physical therapist like John or I that introduces them to these concepts, and then they maintain it after rehab. So um and it's also just a reminder that we're not barbell training or powerlifting just for the PRs and just for competitions and just for the physique. We are barbell training to protect ourselves. And as some people would say, be harder to kill. And Pat, you're proving that, like you could have been more seriously injured, and you could have been in the hospital or rehab longer, but you're not. So that's amazing. And we're rooting for you, and we want you to keep us posted. And if anyone else has questions like Pat or not like Pat about totally other concepts or ideas related to barbell training, powerlifting, rehab, injury, nutrition, orthopedic, whatever, reach out to us. These are stories that we want to share. Even if you're not our clients, we want to share your stories and how barbell training has worked for you to protect you, help you rehab. Um, change your life. So you can reach out to us at no, just kidding. Well, yes, our website is progressiverehabandstrength.com. If you want to submit questions, there is a question form in the whatever you call it below wherever you're listening to this podcast episode. You can join us in the Secret Society of Barbell Mastery on Facebook. We do form checks, we answer questions. You can email us at podcast@progressiverehabandstrength.com. And just check us out on Instagram at Pro Rehab Strength or at John Petrizzo, JohnPetrizz. Oh my goodness, mom brain. And then mine is at Rori Megan _PRS. And that's it. Bye for now. Thank you, Pat. We enjoyed this conversation very much.
Hang on, I have one more. I have one more thing to say.
Oh no, he's going to say something about me mean.
No, not mean, just factual. So,
oh God.
So you and I recorded a few podcasts on.
Oh, this is going to be about.
Listen, and
okay.
we got a very nice email from our former client, Sam.
Oh yeah.
Who loved the podcast, and I promised him that we would give him a shout out on the next podcast. And then Sam, I just want you to know, if you listen to this, that we did not record that last one because of Rori. Rori refused to record the third podcast.
We can record the third podcast.
No, that's it. This is Sam's. No, the moment has passed. But
no, it hasn't. We could still do it.
I did not want to let another podcast go by where Sam did not get a shout out because I promised him that we would mention him. So thank you for listening, Sam.
Thank you for listening, Sam. No, I love, we get a lot of emails about the ones where that we record together. People just like love connect with our relationship and our bickering and that kind of stuff.
There are a lot of other people stuck in rough relationships, I guess. Is that what you're saying?
No, where the wife is always right.
Oh, yeah.
All right, guys, that's it. And I'm going to go upstairs and give you a nice big hug and kiss.
Oh.
All right, goodbye. That's it. We'll see you next time, guys.